Great. Okay, to say that it is an honor to be here is an understatement. I love this community. This is what I have devoted my career to, and I get asked the question a lot, why? Do you have a family member? What brought you here? And I'm being told to speak up. And so just to bring you up to speed as to how I got here, when I graduated from naturopathic medical school in '91, I devoted my career to nutritional strategies for neuroprotection. And after practicing for 10 years, I had about 1,000 patients with multiple sclerosis, a couple hundred with Parkinson's, kids with autism, epilepsy, migraines. I think this is it gonna? Is this better?
No.
Now it's on.
Is that better?
Yes.
All right, great. So about 10 years into my practice, I was alerted to a NIH grant trying to train complementary and alternative medicine physicians in research. Basically what the NIH was saying is that when we ask, two-thirds of people in the United States are using complementary and alternative medicines. And alternative medicine docs are not very good at doing research and publishing research, and conventional medicine docs, when we ask them to study alternative medicine, they basically pull out the Alzheimer's drug, plug in the ginkgo, and they're not using the medicines in the same context that they've been used historically. So our tax dollars had the idea that we need to merge these worlds, and we need to combine more, get more complementary and alternative medicine docs appropriately trained in research. So I applied for that grant, and NIH came back to me and they said, we like you, we like the application. You are so naive to think that you are going to be good at nutrition for neurology. Pick a disease. We'll only give you this grant if you pick one disease that you will devote your career to for the rest of eternity. And it took me about 1/10 of a second to say Parkinson's. Even though that is not where most of my experience was, there is absolutely a Parkinson's personality, and it is a pleasure to work with. Truly, the Parkinson's physicians, the movement disorder docs, have been so much more open-minded and inviting than the other neurologists I had contact with. And I truly believe that this is probably where we are going to get the first big win. I think if we are going to prove that neurodegenerative disease is preventable and reversible, we're going to do it with Parkinson's first. So that's why I'm here. All the slides will be available on the Sparks of Life website when we're done here, so don't feel the obligation to scribble. We're going to make all of these slides available to you to be downloaded afterwards. So my PhD is in nutritional biochemistry. And I just want to talk a little bit about, I also will say I have 2 hours worth of material that I'm going to do in the next hour. But human metabolism is a study of the things that taking in energy, processing it, and eliminating it. And so when we talk about metabolic disorders, we are essentially talking about a biochemical tweak in the system. For some reason, biochemistry isn't working the way it normally should. In every medical school textbook, we have classes on inborn errors of metabolism, things that genetically go wrong. And you heard Dr. Isaacson say, when you ask somebody what causes Parkinson's, you get this quick genes plus environment thing. And so what I want to do is start talking about Parkinson's as really an epigenetic error of metabolism. Something in our environment is tweaking our genes and creating this disease. So it is, when we see that genes plus environment chart, I mean, what we're here today doing is talking about the environmental component. You can't control the hand you've been dealt. You can absolutely control how you play that hand. So what I want to do is bring our attention to the environmental component of that equation. The other thing I want to say at the beginning is when I tell people that I study nutrition, they start asking about what to eat. And I'm not a dietitian. I don't cook. I'm not, this isn't about food. Nutrition is not just about food. It is true that food can be an excellent source of nutrition. It can be a source of anti-nutrition. but there are so many places to get nutrients that don't come from food. We get vitamin D from the sun, oxygen, the water. The study of nutrition is the study of the human dependence on our environment. What must we get from our environment? What must we source exogenously in order for us to survive and thrive? Food's a part of that, but it is a small part of that. I'm personally most interested in non-dietary nutrients. If you take it away and health suffers, put it back in, health improves, by definition that becomes a nutrient. I also think it's really neat that some of the social health, I'll talk about that throughout the talk today, but I think that we see when people are isolated, health suffers, right? And I'm going so far as to say I consider social connection a very, very essential nutrient. So nutritional deficiencies have a million different manifestations, right? Weight loss, impaired sleep, fatigue, skin issues, gut issues. I am not saying that the reason you are here with this disease is because you have a nutritional deficiency. I am saying that if many of your symptoms are symptoms of nutritional deficiencies, and if we don't look to make sure you don't have that nutritional deficiency, how do we know if your fatigue is due to low vitamin D, low B12, or Parkinson's? And what I want to avoid is just because you go to your physician and you say, hey, I'm not sleeping well, I'm tired, I have this skin issue. Well, you have Parkinson's, of course. So many people are dismissed because these symptoms are common in Parkinson's, but that's not an excuse. I mean, so what I want to do is just raise our standards a little bit and not dismiss and accept your symptoms just because they happen to be common in Parkinson's. So this is a game I'll play sometime where, my point with this slide is the fragmented healthcare system that we're currently living in. The question is, which of your healthcare providers is making sure that you do not have nutritional deficiencies, right? So if you had trouble sleeping, you'd probably first go to your primary care doc, right? If you had muscle weakness, maybe your primary care. Lack of coordination, you might check in with your neurologist. Diarrhea, you'd probably be sent to a gastroenterologist. And you can go through this list and start to see how fragmented this is, where different docs manage different symptoms. These are all symptoms of pellagra, niacin deficiency. I don't know that, even myself included, most physicians would recognize a nutritional deficiency if it walked in our office. We only see that part. The GI doc is only measuring the gut part. They're not asking about skin and coordination. The neurologist isn't asking about bowels and diarrhea or constipation. And so we have a whole system set up that works against you because it makes it so hard for your team to come together and talk about, hey, if you combine what you know and I combine what I know, can we paint a picture of this person? And so what I'm trying to do is kind of bring coordinate this a little bit more. I think we have this huge problem, as I said earlier, neurologists have very little training in nutritional medicine, and alternative medicine docs have very, very little training in specific diseases in neurology. So you are all caught between these two worlds of largely ignorant providers. And so that's changing. Like I said, the reason I chose Parkinson's is I really do have a sense that this community is more open-minded than most. So there are a whole bunch of reasons people with Parkinson's are at increased risk of malnutrition. Loss of smell, loss of appetite, if you're constipated, you don't feel like eating, if you're fatigued, if you have apathy. Later in the disease, you can have swallowing difficulties. It can be really time and energy intensive, especially to eat the types of foods I'm asking you to eat, fresh, perishable fruits and vegetables. For people who have movement issues, it's hard to get to the store. It's hard to stand there and chop a bunch of carrots and get, it's way easier to throw a microwave frozen dinner in and eat that, right? And so there are a bunch of things that increase your risk of malnutrition. Sarcopenia is one of the more commonly accepted, in conventional geriatric medicine, Sarcopenia is this loss of muscle mass that tends to happen with age. We all start to lose weight, our muscles start to shrink down and become a little weaker. This is especially prevalent in Parkinson's disease. 1 in 5 of you meet criteria, overt criteria for sarcopenia. And in just general practice medicine, we treat that as a nutritional deficiency. Exercise helps, higher protein diets help, attention to absorption of nutrients. So it is true that this is how we have historically described Parkinson's disease. And the problem that I have with this is it is such a small part of the picture. We have historically described Parkinson's by what the physician can see when you walk in the office, what he or she can measure, right? And it has been a very small piece of the puzzle. I think what has happened, even in the last 10 years that I've been focused on Parkinson's disease, is that the tide has turned, right? All of a sudden, we realize that Parkinson's is so much more than a couple cardinal motor symptoms. We surveyed over 1,000 people with Parkinson's, and the most common symptoms were fatigue, impaired handwriting, loss of smell, memory impairment, muscle pain, daytime sleepiness. The primary symptom, when we ask doctors, what is Parkinson's? This is what we get. When we ask patients, what is Parkinson's? So this is what physicians tend to tell you Parkinson's is. And when we ask patients, what is Parkinson's, you tell us an entirely different story. There's also a tremendous amount of patient empowerment that has happened in the recent past. Many of you know the American Ninja Warrior has kind of changed the face of Parkinson's a little bit. So just kind of to this point, when we talk about what research and industry and physicians are working on, it's improving motor symptoms, preventing alpha-synuclein aggregation and spread. How can we deliver new dopaminergic therapies? And we absolutely need all of that. I'm a clinical researcher. I want all of that too. I want to get to the bottom of this. But it's not necessarily in line with what patients are asking for. Patients need help with fatigue and apathy and sleep and muscle pain. And there isn't much research happening on those things. And it makes it hard for physicians and for patients to feel heard when the team that's caring for them isn't necessarily have the same goals. So the majority of symptoms, according to our research, and I'll later today kind of explain and expand on our research a little bit, but 2/3 of symptoms that people have at diagnosis and all the way through this disease are actually non-motor. Motor gets all the attention, but non-motor symptoms absolutely predominate. And I don't have this slide here, but I will also just say something that I think is really good for you, especially those of you who are a little self-conscious about tremor. We have looked at hundreds of different variables and whether or not they are associated with faster or slower progression, what kind of shape you'll be in 10 years down the road. Tremor matters least. Of all of the symptoms you could have, in terms of what tells me what kind of shape you're going to be in down the road, tremor is one of the best symptoms to have. So I know it's annoying for you. I know it's inconvenient. I know some of you are self-conscious about it. When I see a tremor, I'm like, yeah, right? Like, it's good news in a lot of ways. So we've spent 200 years trying to answer the question, what causes Parkinson's? And what I will say to that is I'm a scientist. I want to know what causes Parkinson's too. But I think it's really important to learn from history, right? And so back in the day, we had something called scurvy that was killing millions of people. 3 million people died of scurvy before we learned that scurvy could be cured with limes. And for 200 years, as long as we have known about Parkinson's, for 200 years, we effectively cured scurvy with limes. And then we discovered ascorbic acid. So I couldn't get a grant to study limes right now until I came to the table with the ascorbic acid molecule. The way the system is set up is first you need the biochemically plausible mechanism of action to get this study funded. And so I like mechanism of action. I want to know what's causing this, but I also will be the first to say, who cares? if it works, it works. Sometimes we don't need to understand the mechanism of action in order to take action. Dr. Isaacson covered how early this disease starts. There are a lot of symptoms people have along the way. I have this slide on here because I'm speaking to the next generation, those of you who brought your children with you for years, often 10, 20 years before people develop any motor symptoms that get them the diagnosis. They have fatigue, they have sleep problems, they have bowel issues, they loss of smell. There are things that I want your children to be on the lookout for, not because I'm eager to label them, but because there is an opportunity here to change the progression of this disease. We do not know what causes Parkinson's, and I'm not here to tell you that I know, but I am very excited about some of the research that's happening. About 2 years ago, this group in the Midwest, they do intestinal transplants in young kids, and every 6 months they were checking to make sure that the colon transplant was not being rejected. And what they learned was the pathologists were under the microscope, and all of a sudden, this 4-year-old's gut looked a lot like the intestinal tract of people with Parkinson's. A couple months later, a 5-year-old kid came through, and they had no transplant issue with their colon, but all of a sudden their gut looked a lot like a person with Parkinson's. And they went back, and long story short, what they learned is that these kids had had viral infections of their gastrointestinal tract, viral gastroenteritis. And after this inflammation of the intestinal tract, the kids started aggregating alpha-synuclein and forming Lewy bodies in their intestinal tract. And that was the beginning of our really understanding that intestinal inflammation causes aggregation of alpha-synuclein. We know, we have people who are diagnosed with Parkinson's in their 60s who we still have a colon biopsy from your colonoscopy when you were 50. We can go back and see that you already have Parkinson's-related changes in your gut 10 years prior. So we have known for a long time that the gut is effective in this disease long before the brain or the motor symptoms. And so we've been trying to figure out what that means. And I think it's time to start asking, if we're getting more and more clear that inflammation causes some of these changes that we're seeing in the Parkinson's gut, maybe it's time to start asking what's causing inflammation in the gut. And the thing that makes that hard is it's probably different for most of you. It might be lactose intolerance for you, it might be a French fries you're eating for you, it could be H. pylori infection for you. And so it becomes a really difficult thing to navigate with your patients to kind of get to the bottom of where's the inflammation coming from. So this is just a picture of inflammation in the stomach and a list of some of the things that have been associated with gastrointestinal inflammation. I'll talk about acrolein after lunch, but acrolein is a chemical byproduct of when you heat fats to high temperatures. Very, very, very common in French fries. And so you can actually have somebody eat French fries and measure their acrolein levels going up in their bloodstream. And there are a number of articles talking about how acrolein will cause the misfolding of alpha-synuclein. So while we're looking for antibodies to alpha-synuclein, I'm going to say just let's limit the French fries, right? I think most people do not realize that 50% of the dopamine produced in the body is produced in the intestinal tract, most of that in the stomach. It is true, a lot of my colleagues will say, yeah, but it doesn't get to the brain, so it doesn't count. I don't believe that 50% of the production of the body's dopamine is irrelevant to health and function. There are dopamine receptors all throughout the peripheral system as well, and not all dopamine needs to get to the brain for it to be effective. But I do think it's relevant, and so many of you have GI issues, and so much dopamine is being produced in the intestinal tract. I think that that's something that we'll see over the next few years. So in terms of the environmental causes of Parkinson's, what do we know about diet? There have probably been about 8 studies, prospective longitudinal studies that are very expensive and very hard to do, where we start collecting data on people when they're 18, 19, 20 years old, and every couple months we send them a survey and ask, what did you have for breakfast? Do you have a pet? Are you married? Are you single? And what we can do is follow these people over decades and look to see, is there anything people were doing in their 20s and 30s that might be associated with increased or decreased risk of Parkinson's over time. And there's a pretty consistent sort of theme that we're finding. We find the more red meat, processed meat,